Welcome and thank you for joining us today for the meeting of the New York City Health Hospitals Information Technology Committee. This meeting is officially called to order. Next on the agenda, I would like a motion to approve the minutes for the Information Technology Committee meeting held on July 16th, 2020.
So moved.
Any second?
I second.
Any questions or concerns regarding the meeting? The minutes, sorry. Then I will call members for their vote. Dr. Katz?
Yes.
Scott French?
Yes.
Barbara Lowe? Barbara? Fenioski Peña-Mora?
Yes.
I don't know if Barbara is on the line or...
Yes, I said present.
Okay, thank you, Barbara. So the minutes have been approved. Thank you. Next, we will have the CIO report and informational item from Ms. Kim Mendez.
Good morning, everybody. As we begin our EITS update, I'd just like to introduce our team members here. To my left, your right, is Dr. Michael Boughton, our CMIO, Sean Koenig, our Chief Application Officer. To my right, your left, is Apoorva, who is our Director of Fiscal Affairs, and also in the room is Jeff Lutz, our Chief Technology Officer. Our update today, we'll do a brief focus on just where we're leveraging Epic. It's our H2O and Cerner lab. Also, just a quick review of some changes to our project management office and how we are now leveraging ServiceNow for demands and requests, and an overview of our health information technology prioritized projects. So you can't see on the slide, which is coming up shortly, but just to highlight that our current Epic sites, we are live at 11 acute care facilities, 1 LTAC, 61 Gotham sites, and all of the T2 testing sites for that initiative, including our Department of Health. We have been able to transition both Epic at both the fixed sites as well as mobile sites, including vans, as well as develop open scheduling for some of the T2 testing sites, so patients are able to self-schedule, and all of the different sites are actually able to use MyChart so that they will be able to see the results quickly, as well as other important patient information. David, if we could move up to the project management office slide, please. So previously, as we're getting to that slide, previously in the EITS, we had 2 separate departments of project management, one that was specifically focused on Epic projects, and the other was on all of the other projects, infrastructure, and other clinical areas and business areas in IT. We have pulled all of those together under one umbrella, and including all change control and communication services. As of March 1st, 2020, we implemented phase 1 of ServiceNow, which is an intake tool for requests that anyone in the system is able to put their request in and have that as part of an IT review. And we completed the rollout after our acute COVID response. We were able to complete that rollout at the end of August 2020, and we now have 5 main routes or categories for individuals across the system to submit a request, or what you'll hear is demand for new services and applications that require IT support. And I won't read through all of them, but they are listed here. In addition to that, we've actually employed an internal PMO assessment tool to give us an opportunity for continuous quality improvement. And some of our immediate findings have been that we have a decrease in overlapping and duplicative requests. We've streamlined our forms for intake from 3 different forms into 1 smart form, which is more efficient for our system. We've seen an increase in system utilization, which actually allows us to have a tracking system in place and have an appropriate allocation of resources, be able to prioritize our projects, and ensure alignment with our strategic initiatives across the system. I'm going to actually turn over to Sean right now, just to walk us through briefly on how the demand goes in and the type and volume of requests, demands we are seeing. Sean?
Thanks, Kim. So as Kim mentioned, we are now live with the Service Now demand module, which allows the entry from anyone within the Health and Hospitals Corporation to enter a request for an IT optimization or modification. And again, we have a number of different routes depending on exactly what the request is. But I think one important thing to note is Mike is going to go over briefly all of the large projects that we have going on. But as a result of the ServiceNow demand module, we're able to quantify and categorize many of the smaller requests that are still necessary for a day-to-day basis and day-to-day operations for the corporation, whether that be the creation of a new department or the creation of a new smart set or order set for providers to use. So there is a link available within the corporation that allows you to go to the request site. It allows you to enter your current workflow, what you're trying to achieve, what you're trying to modify, as well as urgency and your requested optimization. From there, we take a look at that. We work with the appropriate operational owners, the appropriate clinical councils, if it's a clinical optimization, to process that through the system. Next slide, please. So since March 2nd, which is when we went live with the demand module, we've received over 1,500 different demands as of earlier this month. You can see most of them are Epic related or H2O demands, but we have a number of different department creations or deactivations, especially during the COVID crisis when we were updating and modifying the departments to increase our capacity for acute and ICU beds. There were new departments that were created as part of that, as well as non-H2O demands. So again, over 1,500 different demands have come in. And just if we want to take a look at the next slide and just go over specifically looking at some of the H2O demands, you can see we've received close to 900, and of those, almost half have been completed. About a quarter of them are in process, and about a quarter of them we're still working with the appropriate governing councils to approve. So while we're doing a number of large initiatives that, again, Dr. Boughton will be speaking about soon, you can see that we're also managing to complete many small optimizations that should hopefully make the lives and the workflows of our providers, our nurses, and ultimately our patients better.
Thank you, Sean. One of the things to highlight with this system is that part of the process by utilizing ServiceNow is that it ensures that we have a security review on all of the different requests that are coming in, which is paramount for our system, to look to see, is this a facility-specific request, or have we actually looked across our system to make sure that this is a system response, and so that we are not doing one-offs and that we actually do not have any unintended consequences. And the final part is to ensure that we have funding for the specific project and the ask. Our next area is a highlight some of our key health information technology prioritized projects. And I'm going to turn over to Dr. Michael Boughton, who will kick us off with our Epic upgrade.
Great, thanks, Kim. So the first project we'll discuss is our upgrade to Epic 2020. We are currently on the 2018 version of Epic. And the reason for that is that 2 years ago, we decided to accelerate our go live schedule so we could be live with Epic at all of our acute care institutions and our long-term care facility. So now that that is completed, we are doing a little catch up and upgrading to the 2020 version of Epic. That's going to allow us to leverage some best practices from the other leading institutions around the country that have Epic in place right now. You can go to the next slide, actually. And our go live is November 7th of this year. Go to the next slide. The sister project to the Epic upgrade is the Cerner upgrade. We use Cerner for our lab information system. We've already completed phase 1 of this project where we upgrade the code set. We are in the midst of upgrading the hardware. And then in November, we're going to start another code set upgrade that's going to finish up in February. Okay, next slide. I referenced in Epic us having more functionality available with the upgrade. A major component of that is something called the behavioral health module. Behavioral health is an area which is highly regulated and also highly important to us as H&H as a system. What this will do for us is improve workflows specifically around treatment plans for our behavioral health patients and specifically their providers. This is going to go live in May of 2021, but work is well underway already on this project. Go to the next slide. Our enterprise resource planning. This is our PeopleSoft time entry. The current state is a by hand product where you basically fill out your timesheet and it gets signed off. We are upgrading this to a web-based software where this will all be signed off online, where the information will be entered and signed off online. We are going live October 4th with all Group 11 staff and central office staff, and then in later October and November with the rest of H&H. This is a pretty major increase in efficiency. It's a burden on our staff to fill it out by hand. It is also burdensome to our managerial staff for signing off. So this is a major improvement and a time saving for really everybody who's employed here. On CRFP is that's our capital restructure and financing program. It's a quite large project, but what I'm going to attract your attention to today is our telehealth initiative, and specifically our video visits. What we do in an ambulatory, for our ambulatory patients, we offer an integration with MyChart, which is the Epic patient portal, where a patient can come in and have a video visit with one of their providers. We have now done over 7,000 of these, and we did 800 last week. It was 600 the week before that. So we're seeing week over week increases in this service. You can go to the next slide. All right. NYC Care. As you know, we have NYC Care seeks to provide access to care to every New Yorker, regardless of their immigration status or any other barriers. And we are now live in all 5 boroughs with this service. So the IT was a portion of this, and it is now, the whole project is now done and live. So this will be coming off as one of our prioritized initiatives, which will be transitioning to support mode on. Next slide. Our final topic is our Gotham COVID Centers of Excellence. We are going to be going live at the end of this month with enhanced testing capability and then a phased rollout of our imaging, enhanced imaging functionality thereafter. Are there any questions about any of the prioritized projects from H&H?
I have one. It's Barbara Lowe regarding PeopleSoft and the nursing. Will their timesheets and such be done in this phase as well?
I think it's all H&H employees are going to be. So there's 2 phases to this. There's the early October, later October into November, and anybody who is an H&H employee would be included in this.
And Barbara, we've actually had some very specific conversations with Natalia Sinia's understanding, the scope of staff that are involved and the training and support that they'll need at the facilities. And so we are working that out as far as the training on site with champions and super users to support that. And nursing will be in the second phase of the rollout.
Just one more question. Does that marry up with the scheduling that they may be doing on their own? Do the two go together?
So this is in PeopleSoft, and the scheduling is actually in Claravia. So there are currently, they are 2 separate pieces.
All right, thank you.
Hi, this is Feniaski. I have a couple of questions. One is just an explanation. Is H2O another as a component of Epic, or is a different type of system?
Great question. I should have called that out. H2O is our branding of Epic. It stands for Health and Hospitals Online. It is the Epic product.
It's synonymous.
They're the same.
Okay, I thought it was no different. That's one. The second one actually is good. That you put this slide. The version that you are trying to upgrade to is the May 2020 version of Epic. Does that include any modification that Epic has done because of COVID? I really don't know if there have been any specific modules changed to accommodate for the challenging situation of managing COVID patients and all that.
Good question.
Yes, it certainly does. There are numerous here. But one of the ones that I'll call out that we're putting in is the ability to do secure messaging with staff. It allows a doctor or a nurse or a respiratory therapist to communicate more seamlessly, not always requiring a phone conversation. There's a large list of functionality that is coming with this that is COVID specific. There's updates to discharge instructions for our patients. Yeah.
And now that we have this experience to upgrade, let's assume, this is May. Now we're in August. We have learned a lot more about the pandemic, and as we have been discussing over and over, everybody's trying to prepare if there were to be a new resurgence of cases in the fall, but let's say that Epic comes out with a new version. Will it be faster to upgrade now that you have gone through this upgrade?
Yes, it will. This is a fairly significant, this is at least a double upgrade. Our upgrades in the future will be smaller, and upgrading to a more current version of Epic will allow us to leverage their functionality quicker and more effectively.
Okay, and are you planning, like in your kind of planning process of dividing the resources or allocating the resources necessary to be able to be up to date in technology? Because what I have seen a lot of times in IT is that it's sometimes difficult to deal with legacies, and are we ensuring, because this is such a vital component of our operations, and it have shown to be very significant on increasing efficiency. How are we planning in terms of ensuring that we don't have the legacy problems?
Yeah, so tell me if I answer your question here, but we are going to be increasing our upgrade schedule. So we're not going to wait to upgrade 2 years again. We're going to be upgrading multiple times every year from here forward. The reason that this is a large double upgrade was to get our enterprise live on across all of our 11 facilities in our LTAC. That's why there was a delay this time, and that is not the plan going forward for the exact reasons you are mentioning.
Thank you. And the last one, which I think maybe you may not be able to answer, but can you go to the slide that you show the video visits, and you mentioned that all the specialties are now connected through video visits, and I think you mentioned 7,000 visits. My question is more towards one of the things that we have heard when pre-pandemic, we used to visit some of the hospital and some of the clinics. And one of the comments that we heard often was the delay on scheduling specialty consults. Do you see that this slide, do you see that these video visits have reduced the time that it takes for a patient to see some of those specialties?
It is specialty specific at this juncture. We are operationalizing this, and I will tell you 2 specialties that have taken this up, frankly, with gusto, are bariatric surgery and behavioral health. So yes, there are people that it is truly helping our time frame to get in to see a provider. Is it across the board for all specialties? No, that is what we're operationalizing right now and improving.
Okay, thank you. That's all my questions.
Just to be clear, though, it is available for all specialties, but it is not highly utilized by all as of yet.
Okay, thank you.
That's what's going on. Yeah. Surgery and behavioral.
Thank you. So keep going. You want to continue?
Yes, so that actually completes our update, Chairman Pagan. And our next area is we do have one resolution, if we can move to that.
Okay, I had then one quick question on
I'm sorry.
I'm sorry, I saw 28 slides in the counter there before. So on the H2O optimization and how that sort of like takes place, or how do people go in and say, hey, I want to if I'm in a given hospital, I need the following feature. How do you decide priorities on that? Like, so I put a request, I'm at, I don't know, Coney Island, and I want something relatively minor. How long does that take?
Sure. Sean and I will tag team this answer. So we have an enterprise electronic medical record. So a request from Coney Island would get routed to its appropriate clinical specialty. So if it's an OR, as a request related to our operating rooms, it would go to our peri-op council for prioritization, and it would then come to our group for a conversation around value. And what I mean by that is it could be their number one priority, but if it's going to take 8 times as much work as the number 2 priority, that's a conversation we have to decide which order we're going to work on them under.
And we do have a committee that covers a number of different specialties, includes a number of different central office as well as facility groups that review all of these optimizations on it was, I think, bi-monthly before.
Yes.
And I think we did shut that down due to COVID and kind of went with a more expedited process where certain people were reviewing these twice a week, actually. But we're looking to bring that group back again. So they're reviewed about twice a month by facility operations as well as central office folks.
So if I put a request, for example, I would know whether it's going to take 2 months, 2 weeks, 6 months. Somebody will contact me and say, hey, it takes steps on the process.
So generally, So generally, once a request has come into the system via ServiceNow, we have approximately a 2-week turnaround, by which time someone from the IT team should be reaching out to the end user and giving them a disposition of, this is something where it needs to Dr. Boughton's point, this needs to go to the peri-op council, let's go together, et cetera. So we try to make sure that we're in communication. We have a number of reports that we're starting to roll out that help us keep on top of that. So we do try to make sure that we're providing feedback to the people who have entered the requests as far as what the disposition is, whether that is we're moving forward or it's not a priority at this time, given other top priorities.
I think the other thing that the ServiceNow allows us to do is when we get a request in, we might get 4 of them from the emergency department, and then what's the capacity, of our analysts to work on 4 of those, but we may have one over here in Cadence or HIM or another business area or another clinical area that we have analysts that are available. So we look at capacity and prioritization as well when we are assigning the optimization and the updates, so that we keep everybody, engaged and moving, and that we're really activating and utilizing all of our resources equally.
I have yeah, go ahead, Barbara.
All right, thank you. I just wondered if we have 2 minutes for a sidebar on analytics. And what I mean by that is, the great question that we have organizationally all the time is how we're doing and how does that feedback help improve staff satisfaction, patient care, patient satisfaction, and financial performance and effectiveness of our services. I'm just so hungry to know how well we're doing. Oh, I know we're working towards that, because I know you, Kim. But that's one of the things that down the road will help us greatly. Well, not even down the road. I mean, that's clearly important to our performance assessment.
Can I make a request that something like that is sent to us in writing, maybe by email, so that we know, so you have time to think about that?
That it's not an esoteric question. It's what we do all the time, but it's done manually and by the wisdom of individuals usually. But it's just something, a sidebar we can put on the shelf. I'll come back with it another time.
I'm happy to elaborate on this. Our chief data officer, Alex Izagari, would really be ideally positioned to answer this question. But what I will tell you is that having Epic, or H2O, was pivotal to our response to the COVID crisis. And the example I will give, and you're talking about analytics, is to understand our capacity across our system. Being that all of our sites were on Epic, it allowed us to really fairly evaluate what our bed capacity was, do an apples to apples comparison, and then helped us transfer our patients from our hardest hit hospitals to those less hard hit. So it's critical. We have it up and running, and it is something we continually work on. I'm happy to field questions offline on that as well.
Right. And
Yeah,
we're
thank
happy
you.
to follow up with more detail on that. I mean, both from the Epic reporting as well as our data and analytics from a enterprise data warehouse perspective.
Yeah,
Thank you.
so much.
Thank you,
Thank you.
Barbara, for asking that question, because that was the question that I had. And I would like to add another component. You were talking about the different requests that you receive from the different units. It will be good also to have some of the statistics on the time to respond. That you're saying in 2 weeks, you normally come back to the unit, to the requester, and say like, okay, what are the disposition, all that. But it will be good to see, okay, from the time that the request is put in until the time that is actually deployed and delivered to them. I think that will also be good to have as part of those analytics. I also would like to add, as you were mentioning COVID, that we are very thankful for the work that you all did, Kim and your team, during this crisis. I think without your infrastructure and the support that you provided to all the units, I think definitely will not have been possible to accomplish everything that was accomplished. So I just want to, again, thank you for all the great work that you did and continue to do, particularly as we prepare to the future.
I thank you on behalf of the whole team and Kevin Lynch.
Thank you. So
That's,
let's go to a resolution and then resolutions now. Resolutions one. By the way, I have 30 minutes, Max, hard deadline on time frame on this. So I don't think we'll take much, but let's get started. So Kim?
So I read it? Okay. All right, I'll read the resolution. Our action item is authorizing New York City Health and Hospitals Corporation, the system, to renew 17 of its information technology requirements contracts, which were previously awarded in 2015. You'll see that in the appendix to the resolution for an 18-month period for health information related staffing professional services on an as-needed basis to meet our system needs for professional IT services, primarily for staff augmentation, with all necessary funding being derived from previously approved program budgets and or budgets to be approved during the renewal term for the project for the amount of $85.8 million. We're here. Okay, thank you, David. So just providing a little background, but I would like to say as the information technology continues to recruit full-time employees for our sustainable staffing model, as well as to ensure continuity of our services and the flexibility for IT to respond in a timely fashion to new projects that we are bringing on every day, and also to ensure that we are prepared for a second potential surge. We, New York City Health and Hospital IT, is seeking to renew 17 of the 20 required contracts for supplemental staff for a period of up to 18 months term from January 1st, 2021 to June 30th, 2022, which will enable our system to meet its technology needs with all necessary funding derived from approved budgets, as previously mentioned. The original contract, which in July 2015 was for a two-year period with 3 one-year options, and then again in November 2017, we took that option for a 3-year term, which ran from January 1st, 2018 to December 31st, 2020. And the types of staff for the supplemental staffing were some very specific project-based areas, in additional to some supplemental staff and also support staff. Thank you. We're good, yeah. So we are requesting a best interest renewal. Understanding that the current state of our contracts that we were just mentioning, the 17, have been competitively solicited and offer good pricing and have been validated by our new right sourcing. And just to refresh memory, with right sourcing, it has been previously approved by the board as our vendor neutral workforce management solution. And we will be talking a little bit about that in a second. The vendors have also agreed to keep the pricing flat, and the vendors have consistently provided sufficient and satisfactory performance with supplemental staff with the requisite skills to meet our needs. We currently, right sourcing is launching with the nursing area for supplemental staffing, and in early first quarter 2021, we will be actually working with right sourcing to fold in EITS services. and therefore having a RFP while planning this transition will not add the additional benefits for New York City Health and Hospital at this time. We do understand, and I think there's an appreciation that while we're working with right sourcing, that we may not have, or they may not be able to offer all the titles that we may need. And in that case, we will actually come back to the board for an opportunity for an RFP for those temporary staff on an as-needed basis. Extending our agreements will also allow us the continuity of our business and allow us sufficient time to phase in with right sourcing and to conduct a solicitation for any additional titles that they may not be able to provide from that program. And it also ensures us the preparedness that we need for emergency response in the event of a second surge. If we could, thank you, David. So key benefits of IT supplemental staffing contracts. These allow us to achieve flexibility and quickly align with our changing technologies, telehealth and other projects that we moved to during our COVID response, I think are some of the key examples that we can underscore. The payment is based on actual services performed, pursuant to the work order. There is no requirement of a minimal payment to the vendors if we do not use the contracts. Vendors provide as-needed service for a wide array of potential technology needs, and these needs are necessary to for required times and for required duration. So all of our projects are not, are time limited. So we may need to bring resources on for some very specific work, and then we would not need those for actual FTEs. In addition, it allows us to secure the expertise and experience that we need, and it allows the continuity without any disruptions or any delays in any of the ongoing projects. I would like to just highlight, and many of these were highlighted actually in our CRFP update just a few moments ago, but there are times where we bolster staffing for limited periods of time for special projects for design or build or testing prior to going into a support or maintenance mode. And examples here are through our capital grants with CRFP. We are using supplemental staff in these particular areas. Also, when we look at our different H2O models, when we're at the very beginning of building and designing those, we bring in supplemental staff to support. And I won't go through all of the rest of them, but we did mention those before. And we were very thankful to have the flexibility in launching all of the 2T testing sites, building in our Epic, our Cerner lab, as well as deployment of devices. I'd like to now turn to review, next slide, Dave. Thank you. Our IT requirement contract spend. Understanding that this is 18 months, so it falls in between two fiscal years, I'm going to turn to Apoorva to provide us with a review.
Thank you, Kim. So this slide gives a historical snapshot of the spend against these contracts for the last 3 fiscal years, and also our future projections for the renewal period of 18 months. For the most part, the historical spend is aligned to the Epic implementation schedule. So for example, fiscal 19, which shows a higher spend, is because most of our go lives for Epic were in fiscal 19. And from fiscal 19, you see a trend going downwards since Epic is now live. For the next 18 months, we also project that the spend will continue to reduce substantially and for the renewal period. For the most part, in the next 18 months, the capital will be aligned to the CRFP grants. We have staffing helping with all of the programs, and that's what the capital spend reflects. The one thing I wanted to highlight is all of our requirement contracts are not only used by EITS, but they're also used within H&H by other departments as needed on a project-by-project basis. Next slide. So on this slide, I wanted to go over some due diligence that we in EITS carry out in order to ensure that we are on the right track for the supplemental staffing. So senior leadership reviews staffing levels every 6 months to ensure that we're appropriately staffed and we are right-sized. Along with the headcount, we also ensure that the hourly rates are relatively flat, and which they have been since the contracts were finalized in 2015. I want to highlight that in June of this year, we were able to discontinue about 93 staffing contracts, and As a result, we project a savings of approximately 12 million for the next 6 months. As part of these, and we did extend some staff because we have certain projects, and as part of the extensions, we did make a strategic decision that all our supplemental staff will work remotely. And we were able to negotiate with our vendors, and we project a savings of approximately 2.5 million related to that. We were able to negotiate our hourly rates for the next 6-month period, and we are planning to leverage this new model going forward of working remotely and projecting more savings as we go forward. I would like to talk a little bit about the MWBE status. So back in 2015, when the RFP was put out, MWBE was not a specific criteria, and our vendors did obtain waivers at that point. But as part of this renewal period, we were able to talk to all the vendors, and they've been great partners, and 2 of them have since got New York City MWBE certified, and 15 vendors were able to submit their MWBE utilization plan to meet the 30% criteria. So we are able to meet the MWBE goals for the next renewal period. And the last thing that I wanted to highlight, and which Kim has spoken about and alluded before, is that EITS will potentially have a certain level of ongoing need for supplemental staff and project-based staff, given the nature of enterprise projects that we have, given the nature of skill sets we usually need, and the implementation timelines that we need to achieve. But we will continue to evaluate our staffing needs and strive for sustainable, full-time steady states through different recruitment strategies, cross-training staff, and other opportunities such as telecommuting.
So we can move to the next one. I'll just highlight that in the package, we do have the breakdown of the MWBE per each of the vendors as well. So New York City Health and Hospital EITS is seeking approval for best interest renewal 17 requirement contracts for the IT supplemental staffing for a term up to 18 months from January 1st, 2021 to June 30th, 2022, with an estimated cost for contract renewal of 85.8 million, with no minimum usage requirement, termination for convenience, and spending under these contracts is derived from the existing approved budgets and does not require increase or additional funding. And as Apoorva just highlighted at the end of her presentation, is that we are continually looking at our transition of FTEs to a steady state in 2021, and we will continue to do our due diligence on a 6-month review.
Thank you, Dr. Mendez. So any questions? Let's go one by one. Dr. Katz?
No questions, thank you.
Scott?
No questions.
Thank you, Scott. Barbara Lowe?
Just accolades. Thank you, team.
Thank you, Barbara. And Fenioski Peña-Mora, any questions?
Yes, I have a couple of questions. My first question is in terms of the procurement. So what I understand from this contract was first let out in 2015, and it was renewed in 2017. So that means was beyond of the already established contract terms that were 2 years plus 1 year, and it went for 3 years without any external procurement. Is that correct? I just want to understand how it occurred.
So that is correct. The initial was in 2015 for 3 years, and then in 2017 was extended again for 3 years under that original contract, and that brings us to December 2020.
And now we are asking again for renewal. So
we're asking for right, that is correct. Renewal of up to 18 months as we transition to the enterprise vendor neutral supplemental staff management solution with right sourcing.
Okay, so the right sourcing is just going to be at different types of vendors that you will be able, because what I'm concerned is that we have significant spending and it has been kind of locked with kind of the same vendors for a significant period of time. When we go to right sourcing, is that going to allow for the competitive environment to be involved on the selection of new vendors, or how is that going to work? I'm sorry that I don't understand correctly.
So right sourcing is a vendor management solution. The idea is that once we transition to right sourcing, not only our existing vendors will transition, but it'll also open up the opportunity for other vendors to tie into right sourcing. Of course, there are certain criteria, both legal, pricing, all of those have to be vetted, but that will be the medium through which other vendors can partner with right sourcing. And we will then partner with right sourcing, for example, to solicit a position, and we'll go to that entire gamut of vendors that have partnered with right sourcing. So yes,
So
the answer would be the other vendors that are not on this list will get an opportunity to partner and sign a contract with right sourcing directly, and in turn provide us the opportunity to go to other vendors.
But in that process, are we going to advertise to ensure that there is enough knowledge in the market to go through right sourcing to provide the services? And are these vendors that are currently being renewed will go through a new vetting process? I'm just trying to understand how we ensure that the market is able to participate. One of the things that we have noticed in the capital side is that due to the pandemic, there have been new vendors that have been now coming to respond to the procurement of health and hospital. These vendors were not working before with health and hospital, but has very good credentials and very good expertise and background. So I'm just trying to understand how we are ensuring that we are opening up to all the possibilities of vendors that can provide services and enhance the value to health and hospital, because I'm a little bit concerned about the continuation of renewal with the same vendors without having the entry to new vendors.
If I could just speak to two pieces of that, and Apoorva, please add in. So with our current vendors, they would actually need to go through right sourcing as well and meet the criteria. So any of the 17 that we're asking for a renewal on now, that's what we're going to be working on as part of the beginning the first quarter of 2020 to transition over to right sourcing. It would be up to those current vendors to make that application and meet the criteria for that vendor supplement. In addition to that, we have encouraged other individuals to, they can go to right sourcing now and actually make application and follow the path for becoming part of a participant for supplemental staff under right sourcing, and they are able to do that today.
I may suggest, again, this is just a suggestion, that maybe there is, and again, I know that you have a lot of things, but within your constraint, try to create kind of a mechanism for advertisement so that people know that the partnership exists and that there is an opportunity, it's a new way of procuring. We just wanted to broaden the field for everybody. I know that Jose has to go, but I have another question. But two questions. One is that of the 20, you only selected 17. Is there a possibility for you to share why 3 didn't make it to the renewal phase?
Yes, certainly. Of the 17, 2 of them we actually did not utilize their services. And so that was one reason. And the third one that we did not select was not able to meet MWBE or have the desire to do so.
Okay, thank you. And then the last one is about the NWBE. Now, again, thank you for your effort on ensuring that we made our goals of NWBE with all your vendors and really working with them on that. As we go through right sourcing, that NWBE requirement is still part of the equation for them to meet as they seek to work with different vendors to provide the supplemental staff for the health and hospital?
That is my understanding.
Yes, and I think the right sourcing contract itself also has to satisfy the MWBE criteria depending on their pool of vendors. So yeah, even from a right sourcing perspective and an individual vendor perspective, they will have to meet that.
Okay, thank you, Jose.
Thank you, Fanny. A follow-up question on that is then, when you are with right sourcing, right, then it means that we work with them to make sure that they have the process that we want to use. For example, 30% MWBE, and then some sort of
Yes.
rotation for that. So we give them those parameters, and then they find people for us, basically. Is that what it is?
That is correct. And then there is a tracking mechanism as well for the services that are provided to us underneath the right sourcing contract from an
Okay.
MWBE perspective.
Do you think that you'll end up with many titles that you'll still have to do an RFP later on, or you'll be able to
We
get
don't-
it through right sourcing?
There may be some specific architectural type of engineering type of specialty for very special projects that we may not be able to get with right sourcing. Our goal is to work with them to ensure that we get at least 90%, if possible. The other thing I think is important is that the contracts that we are using now will have the opportunity, if they meet the appropriate criteria, to work through the vendor, through our vendor, our solution, what's the word I'm looking for? Our vendor neutral for workforce, right sourcing, and they will be able to provide the same services or some of the specialties that we are currently using, but under right sourcing and meeting all of that criteria, as well as that would be open to a larger group of individuals who can be providing those services to us. So it should be able to give us additional options, is what I am anticipating. But as we do this vetting process, starting at the beginning of the year, I think it will become clear to us very quickly where we may need to reach out for an RFP for additional very specific skill sets that we are not able to find with right sourcing.
Okay, thank you. Okay, I'll call each committee member individually. Dr. Katz,
No further questions, and I'm in favor.
Scott French,
No questions, in favor.
Barbara Lowe,
Yes.
and Fenioski Peña-Mora.
Yes.
Jose Pagan, yes. So the action item / resolution is approved. Any old business? Thank you, Dr. Mendez. Any old business for the meeting?
We are good.
Thank you. So the meeting is adjourned. Thank you.
Thank you very much.
Bye.
Thank you.
Thank you, everybody.
Thank you.
Take good care of yourselves.
Thank you.